When we were growing up, there are few people who committed suicide. I'm sure you saw somebody who used to walk naked somewhere in the village.
Yeah, exactly.
In my own opinion, I think the biggest healthcare issue that we have right now is mental health. If your grandfather killed himself because of depression,
Yes.
you are likely to have that depressive disorder compared to someone who doesn't have a family history. Personally, I come from a family of high blood pressure.
Yes.
When you find a baby with 4-5 kgs,
Yes.
there's a huge possibility that the mother had high blood sugars. People
Improvement.
don't lose weight from going to the gym. I think maybe 10% or 15%. Because again, when you go to the gym, your metabolism gets high. You're
Yes.
consuming a lot of energy if you're lifting weights.
This year, I visited Busia County, and every household I visited, there's someone with type 2 diabetes, high blood pressure, and some even say they suffered a stroke. So families are finding themselves spending a lot of money to keep their family members alive. But I asked a simple question: why don't we talk about our lifestyles? Because in our own households, we have people who are overweight, some are obese. But in most cases, they ignore the fact that their weight could be the reason they have type 2 diabetes or high blood pressure. I don't mean necessarily that, but when you look at science, there is a relationship. And today, I have someone who will explain exactly why your weight really matters and you should think about it. Doc, welcome to Owen Raw Podcast. And I've been waiting for this day so that one day we sit and have a conversation about this. I remember last time when we met in Busia, not actually in Busia, it was in Bungoma, we talked about, these non-communicable diseases increasing in places that people never expected. Nobody would even think that at some point someone would have type 2 diabetes in Western Kenya because we think, we eat organic food and all that. So today I want you to really explain to us what is happening. But anyway, before we get to that, some people would wonder who is exactly, I've said doctor, but it's important at least you introduce yourself to people. Yeah.
Thank you for having me on the podcast. It's a pleasure making a debut on your first podcast. My introduction. Okay, my name is Mbiti, medical doctor by profession. I do several things. Currently, I'm doing my master's in psychiatry. I'm into digital health. I'm into public health. I'm a public health expert.
Yes.
Of course, I'm a hustler, an entrepreneur. Yeah, so many things, but more importantly, I'm a doctor.
Yes.
And definitely the work of a doctor is to ensure that we have a healthy living. And so we are in the business of ensuring that people become self-aware. I think we always say knowledge is power.
Exactly. Last time we met in Bungoma. Yeah. We met in Bungoma, and as I mentioned, we talked about what is happening in our society, and we were like, okay, at some point, tutakaa chini, we see what we can work on. And also, just recently on Twitter, I've realized you're very influential on Twitter. Yeah, and I saw there's a member of parliament, I think game member of parliament, someone by the name is Elisha, who said
Yeah.
that the government should investigate why we have so many cases of cardiac arrest, people are dropping dead and all that. And there's a case of a journalist, I don't know where exactly it was, but it appears he suffered a cardiac arrest and all that. And I saw in your reply you talked about the lifestyle. Can you maybe tell us more about cardiac arrest and lifestyle and all that?
No, I think I said I said we have, when you have non-modifiable risk factors, you are basically non-modifiable means there are those risk factors that leads to diseases. Yeah. So when you're talking about non-communicable diseases, you are talking of things like blood pressure. You're talking of things like cancer. So there are those things that predispose you to these conditions.
Exactly.
Yeah. So there are two things we talk about. We talk about non-modifiable risk factors and modifiable. Non-modifiable basically means it's something that you have no control.
Yes.
So one of the things that we talk about is genetics or family history. So personally, I come from a family of high blood pressure.
Yes.
I've been hypertensive for the last 10 years, since when I was around 21, 20. I was very fit in school. I was a very good soccer player. I would
Yes.
run very long kilometers. But one day there was just, when you're in medical school, you're in the outpatient, so you just go and take your blood pressures for fun, yeah?
Exactly.
And then I found my blood pressure was very high. It was almost 213 over 180. There was serious, there are grades of hypertension, that is severe, or we'll call severe high blood pressure.
Yes.
At 21, you are I was the fittest actually guy in our school football
Yeah,
team.
because I can
Yeah.
see some photos you used
Yeah,
to
so
play. Yeah.
you are wondering how comes at 21 you have that high blood pressure. So
Yeah.
I would go to the hospital. I went to the hospital. All these investigations were done, and then so the doctors were wondering how comes you're 21 and you have high blood pressure. And of course, one of the things that was coming out is my parents are hypertensive. So when you talk about non-modifiable, there's a genetic or a family predisposition. So for me, I would say there's a family history of
Yeah.
hypertension. So there are things like race. You'll find that some diseases are more common
Yeah.
among different types of people. Okay. So you'll realize those are non-modifiable risk factors. There's things like sex.
Yeah. Yeah.
So there are some conditions that affect females more than male. So those are what we call non-modifiable risk factors.
Okay, because I saw somewhere someone saying, okay, as much as we have genetics playing a very key role in having so many cases of non-communicable diseases, someone again argues that okay, there's a percentage that genetics play, but also when you look at it right now, our modern food environment plays a key role.
Yeah.
Yeah. And also someone says that okay, with genes or with genetics, there's a way we can always play around with it.
So, like I said, that is there. So now what you're talking about is what we call modifiable risk factors.
Yes.
Modifiable risk factors are risk factors that you have control of. So this includes your lifestyle. So we talk of sedentary lifestyle. So sedentary lifestyle basically means you're feeding your body a lot of things. You are, for example, eating unhealthy.
Yes.
You are smoking a lot of cigarette. You're taking a lot of alcohol. You are not exercising. So these are modifiable risk factors. So in our setting, you'll realize there's that genetic aspect, but
Yes. Yeah.
there's this now modifiable risk factors that we are not very much paying attention to. So we are eating a lot of unhealthy meals. Everyone wants to go to
Because I wonder, like as I mentioned in my introduction, when I was in Busia, like to be honest, every household utapata mtu anasema okay, hata kakako ama nani wako ana ugonjwa wa sukari.
Yeah.
So many cases, like every household. And then these people usually now, when you talk of Western Kenya, it is ugali, na mboga, and where you'll say there's fiber. But sasa, with that lifestyle, how come we're having so many cases zinaenda huko?
Previously we used to think hypertension, diabetes is a disease of the rich.
Yes, exactly.
But you know what is happening now? We are having more diagnosis. So what you are seeing is more people are visiting hospitals, and by the fact that you're going to the hospitals, then it means you are picking up more of these conditions. Previously, people would drop dead. In the villages, they will say it's witchcraft.
Yes.
People will have stroke. They will say it was witchcraft. So what is happening now? We're having better detection rates. In literally every facility that you go, the first thing they will do
Yes.
is take your blood pressure. And we have had a lot of campaigns, both in government and non-governmental organizations, channeling or aiming at picking these conditions, especially high blood pressure and diabetes. So what is happening? It's not that it was not happening.
Yeah.
I think it's just the fact that we are doing more diagnosis. People are going to the hospital more. So every time you go to the hospital, there's what we call vitals, and blood pressure is part of the vitals.
Yeah.
When you talk about now generally what we are doing, every feed that we take, when you talk about high carbohydrate diet, the sugar, when you talk about diabetes, for example, basically it's excessive high blood sugars in the body. So we are taking a lot of sugary stuff.
Now, let's go. Let me concentrate on Western Kenya. Because of in Western Kenya, when you look at what people eat, mostly, as I mentioned, it is ugali. Sometimes we have nyoyo, githeri.
Yeah.
So can we say ugali could be playing a role in this?
Not necessarily. You see, in the development of any disease, there are several factors at play.
Yes.
When you're developing high blood pressure, there's what we call primary causes of hypertension and secondary causes.
Yes.
So high blood pressure does not necessarily mean you are not eating well, you know.
Yes.
So we call the pathophysiology of high blood pressure. There are so many things at play. So sometimes when you talk about as you grow older, for example,
Yes.
this is what we call essential or primary hypertension. Naturally, as you grow older, your blood vessels become stiff.
Yes.
You know, normally when you're younger, they are more flexible.
Yes.
So when they're stiffer, you know, the blood pressure in there becomes higher. So we find as the older you grow, that's why when you're 50, 60, you have a higher chance of developing what we call essential or primary hypertension. For me now, you'd expect for younger generation, we call it secondary hypertension, which means there are some other conditions that results to you having high blood pressure. It could be hormone issues. You have excessive thyroid hormones. You could have kidney issues. You know, your artery, this is what you call renal artery stenosis. There are so many things, catecholamine. So there are several conditions. So when you come with when we pick someone with high blood pressure, we try to classify whether it's primary, meaning there is no particular cause.
Yes.
Or secondary, which means there is an underlying cause.
Now, okay, as I mentioned, okay, Western Kenya. You see now from Western Kenya, and then you shift to Central Kenya. And also now, when you look at how people eat in Central Kenya, mostly, you know, you Irish potatoes, you minjao na mixed chakula and all that. And then now you'll find that, especially when you look at the female gender, you find that majority of them find themselves, you know, diabetic, hypertensive, and all that. So in other ways, would we say that maybe this viazi and too much prioritization of carb diet and all that playing a key role to a level now you'll find that these women, they're gaining extra weight and all that?
Like I said, manifestation of diseases is a combination of different things.
Yes.
So you'd argue maybe women from Central, they eat this food and they appear this way.
Yes.
But if you take someone from, let's say, Rift Valley, they can eat the same thing and not appear the same way. So that tells you that, you know, there is that aspect of genetics. There are those people who will eat the same food, will grow big.
Yes.
You'll find naturally in our family, people are naturally big.
Yes.
You know, like in my family, there's no one who is fat or obese. We don't have that in my, you know, but there are those families who are naturally big. So that's the aspect of genetics. I've talked about sex.
Yes.
That's why you'll find perhaps some women appear this way more than male. So that is something that it is not modifiable.
Yes.
Okay.
Yes.
Now, when you talk about, for example, you talk about diabetes, there are two types of diabetes.
Yes.
So the type 1 and type 2.
Exactly.
Type 1 is it's one we'll talk about more genetic. Okay.
Yes.
It appears in young people.
Yes.
It appears because you are producing inadequate insulin. So
Exactly.
for whatever reason.
Yes.
Okay. Type 2 diabetes now, it's what is common. It comes, it's a lifestyle disease.
Yes.
Okay. You are producing enough insulin, but
Yes.
there is resistance to that insulin. So your insulin is not able to deal with the sugars as it should.
How about now, women, especially expectant women? There have been cases where, okay, a woman is expectant, maybe after delivery, you know, with a case of high blood pressure, or sometimes she's diabetic. What really happens?
In case of pregnancies, there are those, you know, a pregnancy is a whole condition. You are introducing a new human body into you. This will definitely affect your normal physiology and metabolism.
Yes.
So there's for example, for blood pressure, there's what we call preeclampsia. So preeclampsia is basically high blood pressure during pregnancies. There is a way the fetus affects the blood, you know, cardiovascular system, resulting to high blood pressure. And normally it's around from 21 weeks. So these ladies it's actually one of the most serious conditions in pregnancy.
Yes.
So the mother has high blood pressures. They were not initially hypertensive, you know. So they become hypertensive during the pregnancy. And normally this blood pressure normally goes away once the baby has been delivered. So when a mother comes in a facility with high blood pressure,
Yes.
and maybe there's something 30, 31 weeks, because it has serious complications. So the mother can have seizures that moves from being preeclampsia to eclampsia. So they have seizures. It affects the blood system.
Yes.
They have bleeding disorder. So it kills. In fact, the only mother I've lost during my practice had that condition. The mother had what we call eclampsia. So she had high blood pressure, and
Yes.
then she started convulsing. And then I took her to theater. We did the surgery very well. The baby came out, and then after 24 hours, the mother died. So it's a very common
So
complication.
meaning now we have cases, okay, modernity is bringing this aspect where at least mothers nowadays go to hospital,
Yes.
because we've had cases where someone, okay, for 9 months you expect her and then you just deliver at home and all that.
Yeah.
But we've also had cases where all that happens, but she delivers and passes
Yeah.
on and all that. Now, I also want to understand this aspect of diabetes. I've seen it's called gestational diabetes.
Yeah.
How does it happen?
So it's just the same thing, like with what I've talked about. So gestational diabetes is basically there's increased blood sugar levels
Yes.
during pregnancy. For whatever reasons, your insulin is not able to deal with the sugars in the body during pregnancy, and so the baby tends to get a lot of sugars.
Okay.
So one of the most common complications of that, you have what we call macrosomia. So when you find a baby with 4-5 kgs,
Yes.
there's a huge possibility that the mother had high blood sugars. So
Okay, unapatanga wale watoto
yeah, so
wanazaliwa,
it's called call it is it macrosomia. So you give birth to these huge
Yes.
babies.
Exactly.
So that is a complication, and mostly after the delivery, the sugars tend to go low.
Okay.
And sometimes either they had there's what we call
Yeah,
pre-diabetes.
pre-diabetes,
So they've
yeah.
had incidences, they have some form of insulin resistance that is not outright.
Yeah.
And that's why sometimes it's important to do, there's some tests that we do. There's what we call HbA1c.
Yes.
This test basically, it tests the level of sugars in your hemoglobin. It's called glycated hemoglobin.
Yes.
And that is able to predict your sugars. The half-life of a red cell is around 120 days. So that it tests basically the level of sugars in your blood cells, in your red blood cells.
So meaning after delivery, this gestational diabetes sort of like
That's why it's called gestational. Gestational basically means during pregnancy.
okay.
So after delivery, it tends to the sugars tend to normalize, or rather go lower than what it was.
Okay. Now, Doctor Mbiti, when we talk about type 2 diabetes, there's a guy I listen to. He's a doctor. He's a professor at Harvard University. I've forgotten his name. Now, he says that there was a time he was doing some research, and he happened to go to Uasin Gishu, especially Eldoret, that he would walk around and he would see clinics, and mostly they attend to diabetic patients, hypertensive patients, and all that. And he went ahead to say that you wouldn't have expected, especially people from Eldoret, because they are athletic and all that. So when you look at it that way, and also look at how our lifestyles, how we eat, would we say, as much as we mentioned, genetics also plays a very key role, would we summarily say that it could be our lifestyle that plays perhaps 90% role in all these?
90 is a huge number, but I'll say majority, a huge chunk of it, because when you talk about lifestyle, it's simple. People are eating breakfast. People are eating, especially in these offices. If you go,
Yes.
you've taken breakfast at home. At 10, you take tea. You take lunch. At 4, you take another tea with bread. In the evening, you eat a lot of garlic. So that is lifestyle. Basically, you are adding a lot of fats and carbohydrates into your body. So you're straining your pancreas in the process of releasing insulin.
Yes.
You have insulin resistance. So when you talk about sedentary lifestyle, it basically means you're taking a lot of unnecessary things that you have to take, number one. Number two,
Yes.
you're not having mechanisms of utilizing whatever you have taken. So
meaning you're consuming more and more.
So you're eating a lot, you're not
Yes.
exercising to get to utilize whatever energy you're taking in. So you're just sleeping, you're drinking a lot of beers, you're
Yes.
just there. You don't have a way of getting rid of some of these toxins that you have. So you tend to have a pile up, So
Yes.
you're constantly adding more sugar, more fat,
Yes.
in your body. So this one strains your insulin. So insulin is forced. That's why you call insulin resistance.
Now you've mentioned fat, and now I looked at someone online, Kabuda. Okay, this guy. Okay, people have been telling him, okay, it's your choice and all that. But I've seen, especially online, even in America, where you can have one fit guy and another guy. I wouldn't say obese, but let me say obese. Okay, these people work together. Like this fit guy, for him, he promotes these healthy foodstuffs and all that. But this obese guy, in most cases, is consuming ultra processed or processed food and all that. So the fit guy would always, perhaps hide somewhere, shows up unexpectedly, kicks this food and all that. Okay. So I'm seeing a situation where when it comes to advertising or promoting some products, they can have a fit guy and this other obese guy. Now that raises the issue of someone like Kabuda. People have been talking about him and I believe for the last 1 week. Kila mtu anasema Kabuda. Perhaps those organizations or those hotels that are feeding you, we're going to take them to court. But again, someone says, okay, is someone who is responsible. Now,
Yeah.
when you look at, I don't want you to talk about Kabuda, okay? But I want you to make people understand when you talk of fat of what level, and without even going to hospital, at what point would someone say, hii fat yenye iko kwa mwili wangu, it can put me in a danger zone?
I think there's what the micro and the macro. They're those what we call good cholesterol.
Yes.
It's HDL, high density lipoprotein, and then there's bad cholesterol, the LDLs. That is at the micro level. We go to the hospital. We do a cholesterol profile on you.
Yes.
That's at the micro level. So you're supposed to have high HDL
Yes.
and low LDL and VLDL and triglycerides. Those are bad cholesterol. That is at the micro level. Now these are the macro level. What you see.
Yes.
Okay. You can see your fat, your tummy, your neck,
Yeah.
So there's that what you see at the macro level, and fat is basically what you consume. You're consuming a lot of bad diet, the chips dipped in fries, the pizzas that you take, and everything that you take. And most of the times, the simplest manifestation of it is what you see.
Yes.
This guy is huge, this guy is fat, but now these are the micro. It does a lot of things. So what basically happened is
So now, at micro level, that means it's sort of like what someone can't see with.
Yeah, so things like stroke, when you talk about stroke and heart attack, it's basically you're having a lot of fat.
Yes.
In your blood vessels.
Yes.
What we call atherosclerosis. So there's always a deposit of fat on your blood vessel. Okay, so assume you're fat.
Yes.
Number one. So this is how stroke and heart and what we call them heart attack comes about, or angina.
Yeah.
So basically you have fat that deposits on your blood vessels. Okay, and then there's high blood pressure now that further corrodes the.
Yeah.
So you form what we call an atheroma, so something that blocks the blood vessel.
So meaning now, when blood has to flow, like blood sort of struggles.
So it fails. Yeah.
There's no that path is not. It's narrow to push. For blood flow. And
Yes,
all that.
and that's so when it happens to the brain, that's when you have stroke. Yeah. So there's non-hemorrhagic stroke. So basically, this is a stroke because the blood vessel that is supposed to supply a specific part of the brain is not able to, because the vessel is blocked. When it happens to the heart, that's when you have the heart attacks or angina, because blood vessel is not able to flow to a specific part of the heart. So the heart is not able to work.
Now, meaning, maybe for our audience, as long when someone is overweight or obese, this person sort of predisposes themselves to such kind of risks.
Yes.
So with the overweight and obesity.
So what will kill you? What will kill you is stroke,
Yeah.
What will kill you is heart attack, or you get diabetic complications,
Yes.
so you become diabetic because now, for example, that guy you're mentioning, there's a huge chance that
Yeah.
he'll be diabetic. Why? Because he has a lot of fat, so
Yes.
the fat has to be converted to sugars. Okay, so basically you have a lot of sugars in the body, you have a
Yes.
lot of fat in the body, but you have just one hormone that does that work, which is insulin. So that's why sometimes you are given insulin,
Yes.
or you are given drugs that help insulin.
And Dr. Mbiti, there's also something that I would like to understand. How come when someone is overweight or obese, they tend to eat more and more?
Yeah.
And usually they don't see a problem with that.
There's a hormone called leptin. I think
Yeah.
leptin is a hormone that's responsible for appetite. These people tend to have high
Yes.
leptin activity in their body. They tend to crave more. They tend to get hungry more. So it's sometimes, really, to some extent,
Yes.
it's sometimes, when you have that urge to eat. But now I always say, I was telling my friend the other day, he's a lawyer and he's becoming quite fat.
Yeah.
I told him, when the money is coming,
Yes.
make sure you live to your 40 to enjoy your money. So what do you
Yeah.
do? The best thing that you can do is just take the right meal.
Yeah.
Substitute the high carbs that you're taking
Yes.
with just nice meal. You can take, greens. You can take some good meat. Do away with sugars. Do away with wheat. Do away with chapati. Do away with chips, rice. Those things that are high carbs.
Yeah.
Substitute them. So if you have to eat, number one, try to eat the right food in the first place, and then number two, then we reduce the frequency. People talk of fasting. You try to skip some meals. You don't have to eat. Personally, I eat once a day.
Yes.
I only eat once a day. And it's something I've trained. I don't need a breakfast. I don't need lunch. So I normally eat at around 5, 6, or 4, 5.
You see, now, in fact, you've talked about like the quantity, like you being keen, on your nutrition. What exactly, like fixing your nutrition? And I've seen, to be honest, because at some point I used to go to the gym. You'd find that someone trains for 2 years, but still they haven't lost weight. And someone would always say, okay, for gym trainers or personal trainers, usually for them it's about weight train. But now you train, you don't see
No,
any
you don't, people,
significant
people
improvement.
don't lose weight from going to the gym. I think maybe 10% or 15%. Because again, when you go to the gym, your metabolism gets high. You're
Yes.
consuming a lot of energy. If you're lifting weights, if you're doing those, whatever.
Yes.
So there's a huge probability once you're from the gym, you'll feel like you need to eat. So you came from the gym, you eat.
Yeah.
I remember when I used to go to the gym, at first I would eat twice as much. I would
Yes.
eat more ugali than what I used to eat.
Yes.
I would pump myself with a lot of food. So you realize the kind of gym that people go to, it actually increases their feeding habit. So it's like you're going 2 steps forward, 1 step
Yeah.
back.
So, okay, let me interject. So, meaning, okay, for the gym is good, right? But now, when it comes to if you have to maybe lose weight,
So there are specific exercises that you do to lose weight. You
Yes.
can, for example, if you run on a treadmill, if you do skip ropes, there are specific targeted kind of exercises. For example, that's why you can run. You don't
Yes.
have to, if you want to lose weight, you don't have to go to the gym. Just run,
Yeah.
or go to the treadmill, or do this early morning runs,
Yes.
early morning walks, because they help. But when you go intense, you have to lift weights, you have to do those things. Definitely, you're consuming a lot of energy, and the body will naturally demand you to replenish. So you end up eating more. So the best way to lose weight is to fix your diet.
Yes.
Remove the bad things you are eating, reduce the frequency of eating, reduce the quantity of food that you're eating. Actually, it works. Anyone that has lost weight significantly, they'll tell you, it's fasting, it's me changing my diet, it's me doing away with bread. I don't understand why people eat bread,
Yeah.
and things like chapati, whatever. I don't understand why you
In
don't do
fact,
that.
Doc, now you raised a very important issue. You talked about bread and all that, and I remember at some point there was someone who was admitted actually for 2 days. He was a inpatient, and every morning for breakfast, this person was served with bread and all that. How come hospitals with the whole understanding that when you eat maybe bread, maybe it will spike your, I mean, your blood sugar and all that. But still, they serve people with that.
I think every hospital should have a nutritionist. Most doctors are not good nutritionists. In serious, in our society we just do things the way we're used to. But if you go to serious hospitals,
Yes.
there's a nutritionist who gives. In fact, you're given a specific food. Is it menu or schedule on what you're supposed to eat? A food diary, a food menu.
Yes.
So that's why in every hospital you have what we call a nutritionist. So if, and also it depends, if somebody who is not necessarily diabetic,
Yes.
you can't deny them to take 1-2 slices of bread.
Okay.
But if you're diabetic, people talk about brown ugali, brown bread. There is no difference really, if you ask
Really?
me. The only difference is that
Between brown ugali and
if you are diabetic and you're taking brown ugali and brown bread, there's no, the only
come on,
difference.
doc.
Yeah, it's a very interesting thing that we believe. The only difference is that for white bread and white ugali, it's processed faster.
Okay.
So we take white ugali or white bread, the sugars rise faster. But
Because
uh
I've seen in like our villages and all
yeah,
that. Okay, when someone is diabetic, wanatoa hiyo ugali ya mahindi, tunaweka ya muhogo, and we feel maybe plus
ugali ya
sorghum
brown,
and all that. Yeah.
because it's still sugar. So the only difference is that the brown ugali takes longer.
Okay.
So you eat it, but the body takes a longer time to metabolize it. So the sugars rise slowly compared to the white. So the white, it's easily metabolized, the sugar level shoots up. But the brown one takes longer. At the end of it, all the net effect is increased sugars. So the best thing is just to avoid sugars if your diabetes is on the roof.
Okay. Doc, there has been a conversation, in fact, even online and all that, where people say, for type 2 diabetes, it is reversible. Yeah. And I've heard, okay, the people talk about like these non-pharmacological interventions where you don't have to use drugs and all
Yes.
that. But if you just focus on your diet and all that, truly, okay,
So approach to treating diabetes depends. Like I said, there's some tests that are done.
yes,
You do normal blood sugar, random blood sugar. There's what we call OGTT. You go and fast, you come in the following morning. So they're quite, and then there's HbA1c that I've. So once we come and we take your sugar, we see it's high,
yes,
we need to do some investigations, okay?
yeah,
And then depending on how your sugar is, especially the HbA1c, we'll say, let's put you on non-pharmacological intervention. So this involves diet. They talk of DASH diet. So it's
yes,
basically you're taking greens, you're taking, this white meat. Basically, you're taking non-sugars, yeah?
yes,
And when you talk about fruits, there are fruits that are sugary.
Yes.
When you take mango that is sugary, banana that is sugary, it still has sugar. So there's some specific fruits that, like the lemon. So the ones that are low sugar.
okay,
And then another pharmacological intervention is exercise. So we talk about you doing your exercise, walk around, run around, shake, basically lose that weight so that
Okay.
you don't burden.
So can someone who is diabetic engage in vigorous exercise or?
Yeah, you should engage in vigorous exercise as long as your body allows. It's different now when you have diabetic complications that are coming. But at that age, do a lot of vigorous exercise, run a lot, play football a lot, run,
Yes.
avoid unnecessary eating. So that's what we call non-pharmacological approach. So some patients are put on this
Yes.
and they're followed up after. In fact, when I used to work in active clinical practice in Bungoma, we used to put a lot of these people on non-pharmacological programs.
Yes.
The only challenge is discipline. When you tell someone don't eat this, they eat. When you tell someone do this, run, they do one day. So I think compliance or adherence is just the main issue, and
Yes.
discipline. Yeah, there are those who get there, but there are those who now the sugars are quite high.
Okay.
And you are forced to now put them in
Yeah.
medications. So most of these people are in both. So you give them one anti-diabetic medication, and then you engage in this vigorous non-pharmacological approach.
In fact, there's a guy who tells me that if you went to Upper Hill, especially during lunchtime, you'll see people skipping lunch and walk.
Yeah.
Okay. And also last time I was in Nyali, every evening you see people
Yeah.
are walking and running and all that. But again, now for a majority, people still feel that, for exercise, it is meant for perhaps middle class and all that. Even when we talk about the gym and all that, people feel it is for a certain class. So what message can you have for those who think that exercise is just for...
No, no, everyone, I think we're all human beings. We have the same, our body works the same. The physiology of these things is the same. When you eat ugali, whatever happens in my body with the ugali, the same thing that happens to you. So it doesn't matter which class you are. In fact, you'd find naturally when you were growing up,
Yes.
you'd see now these days there's a menace of obese kids.
Yes.
Do you remember growing up? Did you see any kid who was fat?
No,
As
you
you
wouldn't
grew up,
see that.
there was
You
no
wouldn't.
fat. There were no fat kids, and there was a huge
Exactly.
probability that the kid that was fat came from a rich family.
Yes.
Yeah, so they were being fed chips, those things. As we were coloring those murendes and
Yeah,
those,
yeah,
we'd run around, we'd play a lot of football,
yeah,
we'd participate. So there was hardly a
yeah.
fat kid in a
Exactly.
primary school, for example.
Exactly.
Right now, you go to these schools, everyone is fat. So
Yeah,
they're on video games, they're taking all those things that you talk about, chips,
yeah.
pizza, KFC, you know. So and they're not exercising.
Exactly.
If you go this, as we grew in vast land,
Yes.
you'd go in a whole pitch. Now if I go back to those places, somebody has constructed something. In Nairobi, you see here,
Yeah, yeah.
kids are just playing on the parking lot. There are no those physical places where they can run and have those. So they're going to have a very big problem in a few
Yeah.
years of obesity, and now subsequent complications of it, which are the medical complications
Because
of it.
you see now for children, okay, not necessarily even for children alone, even for adults. Okay, you drive to work in the
Yes,
evening, again you're driving and you go directly to
the
the
car is a
house.
menace.
You see now for children also, from school. Number one, you don't have enough space to play.
Yeah,
So from the classroom,
you hop
that
into the
bus,
bus home.
home,
Yes.
video game, and all that.
Even me, I remember I became fat the moment I bought my car. I used to walk 200, 300 meters from my place, but I would just had to, pick, like here from where I stay, it's around,
Yes.
I've seen it's around 2 kilometers.
Okay.
That is something that normally I would walk 2 kilometers to get to the main bus station for me to go to work before. Now walking even 500 meters appears like it's something very heavy.
You see?
And so we are all at risk. So when people are dropping dead around, people are getting stroke. I think you saw there's a famous musician, a lady, very young. So
Yes.
people, very young people are getting strokes. Very young people are getting. Even the other day, this guy who died, he was an actor. I think he's fairly young. I think he should
Yeah.
be. If he's too old, he's in his 40s. So young people are also becoming victims of stroke and heart attacks.
Yeah.
So it's a menace that people need to pay attention to.
And Doc,
Yeah.
we focus so much on people, okay, these overweight and all that. Now, there's also some people say, we've seen people who are not like overweight, like when you look at them like
Yeah.
physically, they're all like huge and all that. But these people also end up, being diabetic,
And that's why I say
hypertensive.
there's the macro and the micro. The macro is what you see. The micro is what you don't see.
So meaning these skinny people, sometimes they can also have a very high level of fat.
High level of bad cholesterol.
Oh, okay.
So that's why when you go, we do a cholesterol profile. Okay,
Yes.
so you realize you have the HDL is the good cholesterol, but you have this LDL, VLDL,
Yes.
very bad cholesterol. So such a people, you do a blood test, you find that there's a lot that is going in there. And then for such people, also there's the lifestyle. You're taking a lot of cigarette.
Yeah.
Cigarette is a risk factor for many, many, many conditions. It affects almost every organ or every system. So cigarette smoking, it's top up there. So you're smoking, and you are drinking a lot of alcohol.
Yes.
So lean body does not necessarily mean you're fit or you're
You
okay.
can be lean, but you're not fit.
Yeah.
And also, Doc, I want us to focus on the issue of, sexual dysfunction. Wanadada wanna complain. Okay, despite, we're seeing that we have access to information, we know what we should do. to like we feel we are at a point where we can explore our sexuality to the extreme because we have information and all that. But again, women still complain that these guys, as much as they overhype themselves, there's that confidence and all that, when they're given an opportunity, the performance is always dismal.
I think there's that aspect of it being subjective,
Yes.
about what is true performance. There are some women who would want you to do, I don't know, 1 hour on them. There are those, but I think fair enough. 5 minutes is fair, but the issue of sexual dysfunction, you talk about, there can be erectile dysfunction,
Yes.
or premature ejaculation. Those are the main things that people complain about. Erectile dysfunction, mainly, there's a huge chunk of it that is purely mental.
Okay.
So you're stressed, work is stressing you, the lady herself is stressing you. I was telling you earlier, Nairobi,
Yeah.
it's like all women are orphans.
Yeah.
So before you get to her, you have gone somewhere, you have spent a lot of money which you
Money.
didn't have.
Yeah.
You have bought iPhones, people are buying funny wigs, people are doing a lot of things. So you find
Yeah.
by the time even that you're going to meet this lady, you're not psychologically.
Yeah.
So the main cause,
We buy us
so stress, and so most of the erectile dysfunction is, especially on young people, it's mainly a psychological. But that aspect, remember,
Yeah.
what sustains erectile dysfunction is the ability of blood flow into
Yes.
your organs. That is how Viagra works.
Yeah.
Viagra or sildenafil is a vasodilator.
Okay.
So it dilates the blood vessels that go to that part. So sometimes when you have, for example, diabetes, like the same thing I was telling you,
Yeah.
so your blood vessels are thin, blood is not able to flow adequately. So most people with diabetes tend to have erectile dysfunction later, because now the sugars affected the blood vessels, so blood is not able to flow.
Yeah, niliona hata mtu akisema for kabuda and for you. Okay. Okay, I don't want to make kabuda like mainstream this discussion, but someone said, well, for you kabuda we kula bwana, kwa sababu huko hiyo maneno ingine uwezi.
Yeah, so it becomes difficult when you're that huge. You basically, there's very little or not sufficient blood flow going to your arteries down there. So that's how you have erectile dysfunction. Yeah, so that is, so a huge chunk of this issue is sorted by lifestyle, like you've said, and most of them are diabetic.
Yeah. And Doc, maybe as we finalize on this issue of overweight and obesity, there's always tendency for people to store more fat in their abdomen and all that. Okay. And okay, you'll find that you're okay and all that. That's why when we talked about these skinny fat people, but you'd find that at least kuna katami kidogo. How come usually people tend to store a lot of fat around the midsection?
That is the easiest way. I mean, it's the easiest place the body dumps stuff. If you go to a place and you find a dustbin somewhere and you wonder why is it, you'll find that there's something about that place. It's convenient for you to go and throw garbage there, you get. So it's just the same, that at that part of the body, after insulin has tried doing its work, it has tried to sort what it wanted to sort. So that area of the body is the easiest place where fat can comfortably be deposited.
And I checked that the fat, especially around your tummy or in the midsection, is one of the most dangerous one.
Yeah.
What could be the reason?
Yeah. So it's basically because it's huge fat, and it affects basically the entire blood vessel, the entire flow of blood vessels. It's difficult to deal with. They say it's dangerous because it's difficult to get rid of it. Okay, it's very difficult, and of course, like I've explained, fat has a very huge effect. Number one, itself, it causes diabetes, because at the end of it all, fat has to be converted to something. So all of this, especially when you fast, when you're fasting and you don't have enough, for example, carbohydrates or sugars. So in a process we call it gluconeogenesis. So this is where non-sugary stuff in the body is converted into sugar. So fat has to be converted into sugar. That's how, for example, fasting helps, because now that's how you get rid of your fat. So
Yes.
you're not taking a lot of carbohydrates. The fat that you have has to be converted, has to be utilized. So basically, this fat is unutilized.
Yes.
I'm saying so it's dangerous because it's very difficult to get rid of it. Why? Because you are still eating, and the only way this fat can be utilized is if
Yeah.
you are not taking the same carbohydrates. Okay, so that's why when people fast,
Yes.
naturally this
Yes.
thing starts disappearing. It's
Okay.
because now that fat is finding a way of being utilized and being getting rid of the body.
And look, as we talk about, overweight and obesity, lifestyle, and all that, there's also another menace here. I remember someone by the name Juma. She's very vocal on Twitter, where she said, I think someone intimated to her that every weekend, 20 to 30 people, taken to mortuary, to morgues, kwa sababu mtu commit suicide and all that.
People
And
are dying.
I've seen on your side, you are taking a career path where you are centering it on mental health and all that. Can you tell us what is happening, in that sphere of mental health among young people and all that? Yeah.
Yeah, I think the biggest, in my own opinion, I think the biggest healthcare issue that we have right now is mental health. I always say 80% of the people, in fact, almost 90% of the people
Yes.
have mental health issue. It just so happens that before, people are not taking the mental health issues seriously. I mean, when you're growing up, I'm sure you saw somebody who used to walk naked somewhere in the
Yeah,
village,
exactly.
and people would say, "This guy, I'm a rogwa." This guy was like, there are
Yeah.
those people who would see. When we're growing up, there are few people who committed suicide.
Yes.
Personally, all my friends, my best friend in primary school died by suicide. In high school, in campus, I had two guys die by suicide. I've lost like five close friends by suicide, and so for me, there's also I've handled a family history of
Yes.
serious mental health issues. So for me, I think this is a serious health issue that has normally been perceived or has normally been ignored. Remember
Yes.
when blood pressure and hypertension were coming up at first?
Yes.
People ignored it as the disease of the rich.
Yes.
And then it started consuming more people, and a lot of effort
Exactly.
was put into hypertension and diabetes. So I think we're going to that phase now where mental health is an issue. The reason why I am doing psychiatry is basically because of it. Like, I think it's a problem.
Yes.
I personally face a lot of mental issues, stress, challenges, and those kind of things. And mental health is broad.
Yes.
There is the aspect of mental diseases.
Yes.
We'll talk about mood disorder that has
Yeah.
depression and bipolar. You'll talk about anxiety disorders,
Yes.
panic, attacks, anxiety disorders. There's psychosis.
Yes.
People hear things, hallucinate. There is sexual disorders. There is eating disorders. There are so many things. And then there is addiction, the problem of addiction and substance use. So
Yeah.
if you look around, everyone has a mental health issue. So these numbers that you're seeing them, number one, because they're being reported more.
Yes.
And they, of course, indeed, they're increasing more in frequency. There's more incidences of more people are coming out. You get more people are coming out. If I'm always in Madare. I see patients in Madare, and you see the dynamics of this thing. So they are both underlying innate issues and environmental issues that are contributing to this high increase in
Now,
mental
when you
health
talk
issues.
about innate, maybe for our audience,
So
yeah,
innate
go-
basically
yeah.
means just like hypertension and other things we were talking about earlier,
Yes.
there is modifiable and unmodifiable. Innate basically means genetic. So if your grandfather killed himself because of depression,
Yes.
there's a huge chance. So there's a higher probability that for you are likely to have that depressive disorder compared to someone who doesn't have a family history. So when I'll ask, is there a family history of any mental illness? Okay, was somebody in your family? Has somebody in your family died by suicide?
Yes.
As you know, so that is family history.
Okay.
Okay, so that is genetics. So genetics play a big role or a significant role in the pathogenesis or in terms of risk factor of this mental health issues. And then there are those non-modifiable factors, which actually
They call
are
them
huge.
environmental.
So environmental
Yeah.
factors, for example, where did you grow up? Did you grow up with a single parent?
Yeah.
Did you grow up seeing people fighting in your house? Were you how educated were you? What is your
So,
financial
in other
status?
words, you mean like, for instance, if someone was in a in a household where there was violence, this domestic violence, and all that.
Yeah. So what I've seen when I'm seeing these patients, there's
Yeah.
something that is constant, and it's either there's always a family issue,
Yes.
and then there's always a substance use issue. So you see, these are basically these are modifiable.
Yes.
These are modifiable factors. So it could be that, yeah, there's a family history of being predisposed to, bipolar or psychosis, let's say
Yes.
schizophrenia. But there's some things now. For example,
Yeah.
you have grown up in a family where your dad used to fight, your dad was nowhere, your dad was an alcoholic, you were never taken to school, you were abused when you were young, okay, and then
Yes.
now you go out there, you start smoking all these kind of things that people smoke out here. So those, you see, now those are becomes very serious risk factors for you having mental health. I've also paid attention to, you see these guys, if you go to Lower Kabete, I think it's the campus that with highest rates. I was talking to a student leader in the UN, and he was telling me,
Yes.
I need to take my platform there, because in Loakabeti, students are always finding it easy to try suicide, and unfortunately, quite a number of them attempt it successfully. But the dynamics here for me are very. It also shows the paradigm shift in our society.
Yes.
And I was talking to this student leader, and he was telling me. So he was telling me they have done some studies. They're trying to establish, why are people killing themselves in universities? Why are people committing suicide? And
Because these are people who must have excelled in high school, and
yeah,
they had those high hopes. We're going to university to study medicine, to study engineering, and all that, so that we have a contribution to society, make our lives better and better.
the reality, the truth is, the society is changing.
Yes.
We The way we were raised is differently from how these kids are raised.
Yes.
This was funny, because one of the reasons why these guys were claiming they're depressed and want to kill themselves is because they were poor.
Yes.
And I asked this guy, what do they mean they are poor? Because all of us, when we were in campus, we were poor.
Yeah,
We
people
were
are
actually
struggling.
eating 16 bob. Some people had help, some of us did not have help, but we used to go to our friend's room, we cook, we share meals.
Yeah.
So it's not that us had more money when we were in campus. You are
Exactly.
actually facing the same problems that we were facing. So how comes that becomes a reason? And none of us attempted to kill ourselves because we did not have money. You get,
Yeah.
and others are killing themselves because of girlfriends and boyfriends. I think people got heartbroken when we were in campus. I don't have anyone who, a few have done it, but you see, the numbers are not
Yeah.
significantly high. So that tells you that there's something about the society that is changing.
Yes.
From parenting, I think parenting, with the way some of us were raised, is actually part of the reason why we are still holding. So there's very little emphasis on correct parentage. And in mental health, we say the first 12 years are the most important of a kid.
Yes.
There are two people. There's Erickson and Sigmund Freud. Yeah.
Yeah.
So these people came up with the psycho social development
Yeah.
of kids.
Yes.
When you are, there's that we call oral, anal.
Yeah.
That
Yeah.
is
Yeah.
that is
Exactly.
Freud stages. So each of these stages has a significant role of in our growth.
Yes.
And each parent plays a role. So there's an age where a girl will be more attached to the father, the boy to
Yes.
the mother,
Exactly.
and how these dynamics play. So, for example, if you are raised in a two-hold household family,
Yes.
there's a huge possibility that you are more likely to have less of some of these mental health issues, because some of them manifest as what we call fixation. So, for
Yes.
example, when you're in the annual phase, you'll be taught about toilet training.
Yeah. 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 True.
There's phallic phase, you'll be taught about sexuality, and then the Erickson guy talks about at different stages, from infancy to adulthood. There are things that grows in you.
So meaning, okay, for this stage, maybe during development of a child, sh- like there shouldn't be, in case of any difficulty in these developmental stages,
Yeah.
Okay, it is likely to affect
Yes, so
someone's.
you call it fixation. That's why you'll find, for example, if you go to high schools and you find boys who are raised by their moms,
Yes.
you'll be told how they behave. Maybe they are overly emotional. Maybe they are not. They have this. They appear weak.
Yeah.
You get, and this and how they treat their staff. There's that
Yeah.
roughness that comes with a boy. So basically, and how these people later can have now these conditions like anxiety disorders, multiple personality disorders. So the first 12 years of a child, very important.
Now, no, that now puts me in a situation where I find myself so pensive, because today, we are having situations where people are divorcing. We also have people getting children at a very tender age, and eventually, these children are raised by a single parent and all that. And also, we are having a situation where people are not that much into marriage, but again, okay, they're not that much into marriage, but they're also into procreation, because you find that someone is not into marriage and all that, but they end up having kids. So we shall have many kids being raised by single parents. And here you've said we've got a situation where children, especially raised by maybe one parent, like, they're more vulnerable. Now, how is society going to approach all this?
I think that's why I'm in psychiatry, because I think there'll be a lot of opportunities for me.
Yes.
I know a lot of, if you like money, you'll see there's a lot of money coming in, because there are several,
Yeah.
and then there's the internet factor.
Yeah, yeah,
Um,
yeah.
Internet factor is very key, because there are issues that are coming with the internet. In psychology, talk about psychosocial
Yes.
issues. So there's the biology, there's psychological, and then there's the social aspect. If you're growing up young and you're seeing your parents fighting,
Yeah.
and when you grow, you have early childhood. People talk of childhood traumas. I think we are like being liberal. I think I always say, if you look at the American society,
Yes.
I happen to work in the American mental health care space, and it's
Yes.
crazy. It's crazy because there's the disintegration of the family.
Yeah, yeah, exactly.
There's with the disintegration of the family comes some funny values. You talk about sexual queerness that is happening and disorders that are happening.
Yeah.
You're talking about a lot of substance use.
Yes.
And so when they in original, and you find, for example, Indians, I always tell people Indians are good because they have maintained their original family values and
Yeah.
structure.
Yeah.
They have the lowest divorce rates in the world. They are one of the most significantly successful people after the Jews.
Yes.
An Indian comes in this place, and with their family, they are very proactive. They are very shrewd. They are very smart. They are very connected. They have that unity. The same thing that happens with the Jews.
Yeah.
That is because they hold, or even the Chinese, they hold their family values intact.
Yes.
For us, unfortunately, we are actively involved in this integration of the family.
We are becoming, I have a feeling that we are becoming more liberal, more
We are
westernized,
becoming westernized.
where we say, for marriage and family, you will come up with our grandparents and
Yeah.
all that. So, and also we are tying marriage and family to the to the economic aspect, where there's a feeling that, in fact, just recently I heard President Ruto saying that nyinyi mnaanza kutoroka kwa marriage, itabidi muowe and all that. Okay, if you're 25 years and above, you should settle down. But now I read the comments, kila mtu anasema who is ready for that, who is ready for that, because people are now narrowing it down to the economic aspect. And on the side of ladies, they're also saying huwezi teseka kwa babako and then uende kwa jamaa pia uteseke.
I think the societal thing, because I've worked in the villages in Bungoma, and you'll find a 23-year-old guy
Yeah.
happily married with a wife and actually kids. What he does is, maybe he's a boda guy. He's
Yeah,
just a
yeah.
farmer. So
They're raising families.
yeah. So what does that tell you? It's not even about. It's just that there's a paradigm shift in the society. The Nairobians want to appear westernized.
Yeah, yeah.
If today actually you meet two people and you want to get married, you would. But you see, now there are several dynamics. For the lady, there's peer pressure. There is the
Yeah.
internet. There is the there's AI. Currently, we are treating what we call AI-induced psychosis. It's a thing that is happening. Why? Because women go and chat to Chat GPT. Chat
Yeah.
GPT tells them this,
Yeah.
and so that lady comes and projects it. The lady becomes deluded.
Yeah.
So delusions, basically, you're now being psychotic. So you come and project. So there's the internet,
Yeah.
there's the peer pressure that is happening, and so what is happening on one side, men saying they're not willing to get. It's not that they don't want to. It's
Yeah.
because that is where they find themselves in. But you stay
Yeah.
in the villages like I've stayed, you actually see even the issue. Men are becoming terminally sick in their bed,
Yeah.
and their waves are still stuck by them. They're taking care of them.
Yeah, but also when you come to Nairobi, especially cities and at least towns that have developed a little bit where people have access to internet, there's too much pressure where, as I mentioned, everything is narrowed down, to the depth of your pocket. But now when you go, as you mentioned, when you go back to the village, because for instance, if I have to look at my age mates, I think I've got age mates that I can say to some level are more educated and perhaps even better placed economically than them. But you find these people have families. But now for me who is in Nairobi,
Mm.
mtu anakwambia, I remember, okay, if maybe I have to be a little bit not secretive, maybe expose it a little bit. For instance, my own girlfriend, at some point when we discussed marriage and all that, she was like, "Are you ready?" And again, I was like, "Okay, what do you mean that I'm not ready?" Okay, when we have people, as you mentioned, jamani boda boda tu,
Mm.
unashtukia na familia na struggle and all that. Mm. So, meaning we need a conversation about this so that people shouldn't just look at marriage from this economic aspect and also look at it just as a social issue.
I think it's more of a social issue. I hang out a lot with Gen Zs, and I see a problem. They are not. There's some level of maturity that comes
Yes.
for you to be able to sustain uh, a marriage,
Yes.
one, and being a parent.
Yes.
There's a lot of social cultural shift that is happening,
Yes.
and people, it becomes difficult because now it's autonomous. We
Yeah.
live in a very, if you go to these strict
Yeah.
countries. I've stayed in UAE and even goes places like Saudi, where the state is actually involved in your business.
Yes. Yes.
You are not supposed to take, there's an emirate called Sharjah.
Yeah.
They don't sell alcohol.
You see.
For example, in Riyadh, you must hand $13,000 per month for you to even
Yes.
go to a bar. So you see, that is a society that is actually determining what you do.
Yes.
For us, we are liberal. Okay, we have become very liberal. We are very leftist. We allow
Yeah.
people to do their things. We have taken our women to schools. There's
Yes.
a lot of gender equality, or
Yeah.
people have been empowered. So empowerment means your ability to do what you want to do.
Yeah, because I've seen it even in America. People are talking about family. I've seen even the Vice President J.D. Vance and all that, especially the Republicans. Now they're now focusing it. Okay, as much as you want to be liberal, people are now talking about family. That what, after you've gone to school, you have a job, have a family. Like there's a happiness. In fact, there's more success in family and all that. And also now they bring in the issue of birth rates going down, especially in Western societies.
But you see, now it
Yeah.
becomes an ideological issue. When you tell me you are successful in marriage and I'm not successful in marriage, so why should I listen to you? So that's why you see it's a split thing.
Yeah.
I've gone into marriage, I've experienced this in marriage, so I have my own experiences. So it becomes more of an ideological issue. Even the concept of LG, the lesbianism and the
Yes.
homosexuality it becomes an ideology issue. That's why it becomes politicized. The issue of religion,
Yes.
the same thing. So it becomes an ideological issue. It's not factual. You
Yeah.
can't really force. You can't tell me marriage is good,
Yeah.
and
Yeah.
and
Yeah.
I've not experienced it.
And Doc, you mentioned that you're shifting your focus on psychiatry, and also I've seen online you're so big on integration of AI
Mm.
into mental health services and all that. Could you please maybe explain to us what role is AI playing here?
I think when we talk about digital health,
Yes.
and that's why I'm really passionate about. I think digital health, it helps. Uh, Also from a public health,
Yes.
there's what we call primary healthcare
Yes.
and universal health coverage. I'm sure you've heard about it.
Yes. Yes.
What this does, it takes healthcare to the people.
Yes.
So, for example, before when you feel, imagine today you are depressed and you
Yes.
are feeling sad and you
Yeah.
want
Yeah.
to
Exactly.
commit. Where would you go?
Sometimes.
Assume now you are feeling sad, you are low, you are not
Yes.
eating, you don't have appetite, you don't have anything, you're just low. Where would you go?
Sometimes maybe if you have someone who is close to you, you
So
open
you
up
see,
to them.
you're going open. Okay, assume today you have headache and fever and you're vomiting. Where would you go?
Maybe look for a medical facility around.
So you see the difference. So
Yes.
for the physical illness, you are vomiting, you have a headache, you'd
Yes.
go to a facility.
Yes.
For mental health, you look for someone who is not a professional.
Yes.
These are two same things. Both are symptoms of a disease. So these are symptoms of maybe say major depressive disorder. Or you're hallucinating, you're seeing things, you're hearing things. So
Yeah.
you go to
Yeah.
talk to someone, a friend who is not a professional.
Na
Can you
unaongea
imagine you are
watu.
vomiting and you are diarrheaing and you go to talk to someone? So those are the same thing.
Yeah.
So
Yeah.
what digital health does for me,
Yeah.
especially in mental health, is bring accessibility.
Okay.
So you go to my platform, for example, Mbiti.
Yeah.
So Mbiti, I'm incorporating AI and physical care to
Yes.
mental health. So you go to this platform, you sign up, you see, but there you look at this, you do self-assessment.
Okay.
AI powered self-assessment.
Yes.
So these assessments will tell you, but there's a probability that you have this. Okay.
Yes.
So you can converse with a chatbot that has been trained.
So meaning you'll be explaining what exactly
So
you're going through.
so it'll explain to
Yeah.
you, and then you talk to it. Then from there,
Yeah.
you have it directs you now to a provider.
Yes.
We have AI tools, for example, AI monitoring tools. You can
Yes.
monitor your sleep, you can monitor your mood. We have AI powered journals.
Yeah.
You can have a memo there.
Yes.
You can write your journals. You can tell your story. You can record videos there. AI powered video tools.
Yeah.
AI powered therapy tools. And then eventually we integrate it wearable. So digital health basically is any form that has that uses technology
Yeah.
to help with healthcare. So wearables. So
Yeah.
if you're sleeping less, your phone, your watch, Apple Watch, for example, will tell
Yeah.
you this is your sleep pattern. The same way it tells you, hey, today you have not walked.
Yeah.
So that is what we want to do. We integrate telemedicine is also a form of anywhere you can talk.
Yeah.
One of the interesting features that I have, because one of the reasons why you not go to a facility is because
Yes.
of trauma.
Yeah.
And mental health is heavily stigmatized. So I'm building a telepsychiatry platform where
Yeah.
you can be anonymous.
Okay.
If I'm struggling with sexual addiction or masturbation,
Yeah.
there's a huge possibility I will not want to come out clearly.
Yeah.
So we are incorporating a feature where you can go in anonymously, pick a therapist anonymously, have that conversation.
Okay.
So it's important. I think in summary, AI and technology or digital health, what it does basically, it improves accessibility.
Yeah.
It's also affordable, because if you go and see a therapist, they're quite expensive.
Yeah.
So for me, I'm giving like a package of around $12 per month, a therapy session. So
Yeah.
probably you'll be spending around 2,000 per month, which on physical you'll spend more.
So you talked of like you already have your own where you have Mindfiti. Did you say Mindfiti?
Yes.
I hope my pronunciation is okay.
Yeah.
So from your assessment right now, with increased internet penetration in Kenya, what's the level of adoption in Kenya?
We are still low.
Yeah.
But the one thing that you say, the ability of a digital health intervention to work is based on accessibility.
Okay.
I mean, everyone has internet.
Yeah.
We are still collecting data.
Yeah.
Because data is key in everything. We're seeing people signing up. We're seeing the profile.
Yeah.
What is their age group?
Yeah.
What is their gender? What are they doing? So another thing that AI helps, now come up with AI predictive tools.
Okay.
So able to predict these guys are highly likely to commit suicide, highly likely not to take medication, highly likely to be a drop-off. So we are still in that phase of collecting data.
Yeah.
We have not even launched it because, again, we have to deal with things like data protection. So we have to get a certificate.
Yeah.
But the software is almost there. So I think when we launch, everything will be in play.
So, Doc, as we conclude, just a few days ago, President Ruto was in the US where they signed a healthy deal where Kenya is likely to receive about 2 million USD. And I've seen also the Ugandan minister. I saw in the US they signed a deal and all that. And at the same time, this NGO USAID sort of I mean, it's like it's not going to make a comeback, and there is a plan for the US to work directly with the government when it comes to health issues and what have you. Now, there's been opposition, especially here in Kenya, where people are saying that this deal sort of like gives the US a direct or express access to our biodata
Yeah.
and all that. Can you explain it to people, because there's actually some worry. People are really worried that the government wants to expose them to the American government and all that through sharing their data.
Oh,
Yeah.
yeah. I think I've read that document. I
Yeah.
think I gave my analysis as well.
Yeah.
I think in politics and governments, especially the states, they operate in a
Yeah.
quid pro quo.
Yeah.
They go into Ukraine, they're helping Ukraine by taking minerals,
Yeah.
So it's always that. So for this deal, I've gone through it. Of course, there are those concerns that we are giving our data
Yeah.
to the United States. Of course, the United States, it's open. It says this data is key for them.
Yes.
They know why they need that data as an United States of America.
Yeah.
But more importantly, what they are giving us in return, they talk about strengthening for example, the infectious diseases, trying TB, malaria, HIV,
Yeah.
our Camry,
Yeah.
hiring staff. We're struggling a lot. You see, our healthcare system is, so they want to bolster the system, increase interoperability, and those kind of things. So I looked at it and I said it's not the worst of things.
Okay.
As far as what we need, because I said we are just simply a poor country who cannot get basics right. You cannot. So one of the things that they get, for example, access to American pharmaceutical companies in our country, lab into our country. So it's a 50-50 thing.
Okay.
Yeah.
So people could be having concerns.
So the concerns of data, they are legit. We don't know what they're doing with our data. We are concerned. But at the same time, what the government is looking at is they're getting infrastructure of what they have not been able to
But
do.
again, people have been saying, for instance, for malaria and all that, we've had, NGOs providing sometimes, primary health care, without necessarily people asking where is our data going and all that. But now it's a conversation. People are worried about their data, but previously they've been giving their data out.
Yes. So at some point, it's politics. I think sometimes one of the challenges I've had with this government is how they communicate. You see Oluga go to a radio station, and sometimes communicating with humility, how you communicate your things, rather than being bullish about it, helps. Because if in the real sense, they have been collecting our data. But now, because there's politics in it, there's our attitude, this is what we feel about our government, the things they have been doing. We get money from China, it gets looted and those kind of things. So there's always that lack of faith in the government. But if the government communicates and they show clarity, we are giving this and we are receiving this, and this is what has been happening, then I think the public will have a soft or a cordial response to the deal.
Doc, as we conclude, today I have one question for you. But before you respond to this question, what plan do you really have for Kenyans, especially on mental health? Additionally, what is your general comment or advice when it comes to the issue of our lifestyles and all that?
I think it's, for me, the most important thing is we should be informed. I always tell people to read. I like reading a lot, or watching things that feed you knowledge, because knowledge is power. I think most of the things that we fall for is because we don't read and you don't seek knowledge. So for me, when you talk about lifestyle, when you talk about diseases, just try to find out, try to read about it, try to have that knowledge. I always like when I meet patients, and you find patients with chronic conditions, they know, like cancers, rheumatological conditions, they know their drugs, they know their problems, so they know what to do, what not to do. So let's be people that read, let's be people that does a lot of research on our own. When you
Yeah.
talk about diet, just know this.
Yeah.
I think that's the first place. And number two, I think I'm a fan of primary healthcare.
Yeah.
We should always do those checkups.
Yeah.
Those do those per year. Do at least 1-2 checkups.
Yeah.
Your blood pressure, your imaging. If you're feeling those kind of things, just do. If you're a lady, do those pap smears that we talk about,
Yeah. Yeah.
breast checks and those kind of things. So prevention is better than cure.
Exactly.
For the mental health, I think for me, mental health is key.
Yeah.
People are losing their minds. People have issues.
Yeah.
And for me, my goal in mental health is to make mental health accessible. You are seeing these days when you see mental health conferences, they are held in 6-star or 5-star hotels,
Yeah.
but you don't see them going to Madare. You don't see
Yeah.
them in MTRH. You don't see them on the streets. You don't see them in Dandora or Kibra, where we have people who are screwed in the head. So there's a lot of money and activism in mental health.
Yes.
There's a lot of ingenuity or disingenuousness in the mental
Yeah.
health field. There are a lot of cartels in mental health field, but mine is simply empower them. I'm giving you a tool. You can access it by your phone, get
Yeah.
knowledge, seek help. Minimum monetary involvement.
Yes, exactly.
So we are genuine in what we do. So mine, I'm creating an Amazon of mental health where
Wow.
everyone will interact, because I'm also onboarding psychologists,
Yes.
psychiatrists, counselors, and others. So I'm creating an Amazon of mental health. People
Yes.
will come to this pool, and I give you Mindfiti. You talk about it. So that's my goal, and I think by next year this time, we should be quite somewhere with it.
Wow.
Yeah.
That is so amazing, Doctor. So, as we wrap up, I have a question here for you. What is one truth you've been running from?
One truth. I think I've been. That's a very. um, I think I've been running from my fears. I
Yes.
think the ability of someone to self to understand themselves, to self-diagnose themselves, and
Yes.
accept that this is a problem.
Yeah.
So sometimes you have problems, sometimes you have issues, and you're not genuine about it.
Yeah. Yeah.
So you develop defense mechanism. You suppress them. You're repressive. You're avoidant.
Exactly.
And I think that is something that I definitely do a lot of time, and most people do.
Yeah.
But I feel when you confront your fears, when you accept your shortcomings
Yeah.
and
Yeah.
your weaknesses, then that's the only way you become better.
Wow, that is great. So you've talked about Mindfiti. So I was wondering, so if someone goes online and searches Mindfiti, which is MIND, okay, then FITI.
ITI. Man.
Okay, from there someone can get services. Dr. Mbiti, I really appreciate for the time, and I hope moving forward we shall have more engagement so that we educate our people, because truly speaking, overweight and obesity has a relationship with type 2 diabetes, high blood pressure, despite other factors playing a role. It's only that maybe we didn't mention what role is overweight and obesity playing when it comes to cancer and all that. And also we've mentioned that mental health is becoming a very serious issue. It's affecting young people, even adults, and all that. So it's a conversation that we should continue, and I believe that on Owen Raw Podcast, we shall continue having conversations. And until next time, we shall have another episode. And keep it here on Owen Raw Podcast. Bye bye.